delighted that this is our first Sheffield patient floor plan. There's a good buzz in the room and we've got some really good numbers here. So I think this is probably one of our largest packs, so we're really excited about that. So thank you very much for coming. I'm Dawn Lawson, I'm the Chief Operating Officer of the Academic Health Science Network, and it's the Academic Health Science Network that's pulled together this event. I'm going to briefly introduce Michael Harper, who's going to say a few words from his point of view as Chief Operating Officer and what he wants to get out of it.
Today is about looking at it slightly differently, and hopefully you notice that within STH we are trying to do things differently with the Making It Better programme and the work of Becca's team and service improvement and how we're doing things differently there. Some of you will have been involved in the admission and assessment workshop, consensus workshop that we had a couple of weeks ago, and that was a very different way of doing things. So this is something else that we're trying and wanting to do, that pulling people together to look at what is flow, how does it work, and how might we look at it differently, what it is for the staff that we're having to manage and deal with those. So we've got another pressure point then where patients are trying to go from A&E into the assessment units. We know that the assessment units have lots of pressure in terms of how do we assess those patients quickly, how do we get them out to the right ward, how do we get them home quickly. So then there's another pressure point about into the ward area and identifying, and likewise we know at the moment we've got lots of issues both with the very many patients that we discharge back to their own home, very simple discharges, how do we get those out quickly, how do we get them to the discharge lounge, how do we plan for that discharge. But we also know we've got delays in some of our community services at the moment and big issues with delayed transfers of care. And whilst we should be pulling patients all the way along this pathway, there's no doubt that we're trying to push as well, and this is where the tensions grow. And hopefully all of us in this room sit somewhere on this program, and therefore by definition all of us in this room can do something about how do we get that flow and how do we get patients moving and into the right system. So for me that's kind of the problem hopefully that we're looking at today. Flow from that system, but acknowledging that it manifests itself in different points around the system, but that doesn't mean that's the only place where actually we need to tackle it all.
So that's kind of the introductory session. I'm now going to take you into the simulation.
One, that's Janet Sumner. We've now got a transfer from ED to MA2, that's Derek Fox, it's just after 6:15. We've now got discharges from ED, so ED, we need to give Matt Cameron and Richard McRae. They all arrived within about 3 or 4 minutes of each other. I've now got a transfer from Chesterland 4 to CIC, that's Kevin Raitt. I've got an arrival in ED that's Paul Roberts at 20:06. No, so it's been mainly discharging. Transferring onwards or mainly discharging home? Okay, medical assessment. Are you over there?
Yeah.
Right, what have you been doing?
Just in summary, to race through this, there's a relationship between length of stay and mortality. That relationship can allow you to spot risk points, which risk steps up, and you may choose to do something like that. 28-day stay, actually say 14 plus, not 28-day stay, but say 14 plus, a really key group to be looking at. You are achieving progress in that area, and I'd encourage you to keep going with that. There's a weekend effect on discharging patients, which is not insignificant. It's difficult to address, but actually if you could address it, it would give you some headroom back. And ED is showing signs of depression, and it lasts despite everyone's 10 seconds. So it's an absolute whiz through in 15 minutes, I think I've done it in 30, of a really complicated data set. Very grateful for the data that we've had from you.
The purpose about microbiota is going back to that definition that we talked about at the beginning, around making sure that the patients get what they need when they need it, on time and in full. It takes from visual hospital in that it is a visual plan, and the difference between what you would be used to doing on ward and what happens every day is it is a timed plan that we have for the patient. So generally we need to know what needs to happen, but we generally don't record or sometimes even consider when it should happen to that patient. And we normalise delays in the system, so just because something generally takes 3 days to happen doesn't actually mean that that's right for the patient and it should be like that.
We have on here an axis of patient illness or patient need. Okay, and if we have here time, you've got to bear with me a little bit about this. You've got a patient, they're at home, and they get ill. Right? And at that point, they get ill to the stage that they need to go to hospital unless you have sort of services that could support that. So they stay at home with these services, and at that point, they need to be in hospital. They should not be being looked after at home. They need to be in hospital. Proper problem. Then hospital does its magic. And at that point, if we have the services, they could come home. And they get better, and at that point, we withdraw services, and they go back to health. And obviously, if they're healthy, they don't quite get there, they probably get to here, etc. So that's you get the rough idea of this. And what's interesting about this is that these lines basically put the graph in the same place. So the services that you need to keep them out of hospital are exactly the same goods that you need to get them out of hospital. And the problem with the NHS at the moment is that this line here is like this. It's good. So we have patients here who are ending up in hospital because we've not got the services to look after them. It's a job of the NHS to make this area robust. Okay? There's various sort of catchphrases that we use. This area is keeping people well at home. This area is really keeping people ill at home. The most is better. And this area is only hospital when only hospital can. So that's what we use to do. It's this cohort of people that come through that it's cheaper, it's more convenient to look at them at home, and for many of them, particularly the elderly, it's safer. Despite hospital, that's the best efforts.
So we've had a discussion with the go-to group and so on, and here's where the sort of areas we'd like you to focus on. Obviously, if somebody really disagrees and has a better suggestion, we'll have to be responsive. So the exam question for us is, how can we reduce the number of 28-day patients in our hospital by 50%? Is that a valid question? Is that okay? Group 3 and 4. They will be working on the concept of how do we achieve level discharging. Okay, and the third problem statement is, again, for two groups to work on, is how do we create an intelligent flow system, data information system, that helps anybody come to the hospital at any point in time, either at the ward or the hospital, and understand how many discharges are going to take place in the next hour.
Any risks. But we suggest that we need to get these patients out of the acute setting and into their own environments, or at least a non-acute environment. And the way we'd like to do that is to first of all put in some education and training packages for staff in the acute trust to develop confidence and knowledge of what's available in the community, and then use community-focused professionals to undertake that assessment with patients in their own environment.
What we're going to do is to get initially some baseline data. We felt that part of the problem we had in trying to change something and accomplish something was we didn't have all the base knowledge we needed in order to implement change. So the data we would initially be gathering from the ward would be the number of discharges, the number of admissions, and the current time that those discharges happen throughout the day. In an ideal world, they'd already be levelled and the job would be done. I'm guessing from the graphs we've seen that's not the case. So what we would then do is to use that data that we've gathered to plan a discharge level that we'd want throughout the day. So a set number of discharges per hour throughout the day, much as we've seen talked about, accepting that the number of discharges and the times of discharges may be different depending on whether it's a weekday or a weekend day.
Oh, so it looks like Arlene Harper. This was your, this is you. That was your favourite one. Okay. Don't give it away.
Yeah, sorry.
So we decided that our aim
was going to be to increase the use of the whiteboards by 50% within 6 months. And then also an important part of that was to make sure that the data that was in the whiteboards was actually accurate. And we had 2 parameters for accuracy of data. One that we could predict to within the day, so during the patient's admission when they were going to be discharged, and then within a 12-hour window that we could predict within that hour, which is what we were asked to do. We decided to do this with a core project team which encompassed expertise both in terms of the data and the systems, so the actual whiteboards and their functionality, but also in terms of clinical leadership across a range of disciplines, as we felt that was important for engaging the clinicians across the hospital and also for sustaining that spread. We decided that we would build on some training that had already happened, which was targeted training at different groups, and using the PDSA structure go through a number of different cycles as to who were the best people to target, what was the best size of group, and when was the best time to try and target them. Was it ad hoc grabbing people on the wards, or was it specific sessions? But also we recognised that that core project team had some learning for the organisation to do as well, so that we needed to work out how best the use of the whiteboards could fit into staff's daily routines, and also what sort of functionality of the whiteboards was important, because at the minute we felt that the staff had been overloaded with absolutely everything being active on it, and so the core project team would kind of have a dual role of educating but also learning for the organisation.
Oh, so a mix of scores.
So now we've got the energy, we've got some plans, so the future looks much brighter in terms of flow in Sheffield. So thank you very much once again, and we will be in touch after the event. So